Good morning, dear friends. The topic of today's lecture is physiology, pathology of our motor system. You know that a functional unit of the nervous system is reflex. Reflexes fall into two groups, unconscious reflexes and conscious reflexes. Unconscious reflexes, an automatic, instinctive, unknown reaction to a stimulus that are inborn reflexes, limited by segmental level, spinal cord, brain stem. Involuntary reflexes of a person correspond to this type of reflexes. For example, knee jerk, biceps jerk, etc. Conscious reflexes. These reflexes are formed throughout a person's life. A cortex is obligatory involved. For example, Pavlov's experiments. At first, we'll draw an arc of involuntary spinal reflex, for example, knee jerk. Other spinal reflexes are similar to it. While examining this reflex, Dr. taps the patellar tendon with a hammer and observes quadriceps contraction. This is typical spinal arc of spinal physiological reflexes. All our physiological reflexes, knee jerk, ankle jerk, biceps, triceps, etc., have similar arc, the same structure of spinal arc of reflex. There are typical three motor neurons and sensory neurons in this arc. For example, let's describe knee jerk, like a typical spinal reflex. We tap ligamentum patella. As a response, it is contraction of musculus quadriceps and slightly movement of our leg, of our knee. And what is the arc of this reflex? Dendrites of first order neuron receive information about this irritation of ligamentum patella, and this irritation passes via dendrites of first order neurons to the first order neuron. It is a rule, first order neurons for all modalities of sensation. We described it, this information, during my first lecture about sensory system, are located only in one place, spinal ganglion. This is for all modalities of sensation, for all arcs of spinal reflexes, location of first order neurons. Axons of these first order neurons enter the spinal cord and, as a rule, terminate on the second order neuron, which lie in the posterior horn of the spinal cord here. And then information passes to the motor neurons of the anterior horns of the spinal cord, and then exit the spinal cord with peripheral roots, nerves, and information goes to the musculus quadriceps, and contraction of musculus quadriceps provides light extension of the leg. So this is typical arc of the spinal reflex. All spinal physiological reflexes we can divide into two big groups: deep reflexes and superficial reflexes. It's very easy. Deep reflexes, tendon and periosteal. Where is their point of irritation? And superficial reflexes, skin reflexes and mucosal reflexes. Let's describe some physiological reflexes of the person. Biceps jog. Ensure patient's arm is relaxed and slightly flexed. Palpate the biceps tendon with the thumb and strike with the hammer. Look for elbow flexion and biceps contraction, like on the picture. The spinal arc of this reflex is C5, C6 spinal levels and roots. You are to know levels of all physiological reflexes. This is part of our topic diagnostical process in neurology. The second physiological spinal tendon reflex, this is triceps jog. A level of this reflex is C7, C8 spinal segments and roots. Strike the patient's elbow a few inches above the olecranon process. This is a point of projection of ligament of musculus triceps, and look for elbow extension and triceps contraction. The next physiological reflex from the arm, it's not tendon but periostral reflex. This is supinated jog or brachioradial reflex. The spinal arc of this reflex, C5, C8 segments and roots. Strike the lower end of the radius with the hammer and watch for elbow and thumb flexion. Reflexes from the leg. Ankle jog or Achilles reflex. Spinal level, S1, S2 segments and roots. Tap the Achilles tendon with the hammer and watch calf muscle contraction and plantar flexion. We can use different positions of patient. Their position must be convenient for patient and for doctor, and provide relaxation of all patients' muscles. There are different types of patient's position when we check ankle jog. And finally, knee jog, one more physiological spinal tendon reflex or patellar reflex. The level of this reflex, L2, L4 spinal segments and roots. Ensure that the patient's leg is relaxed. Tap the patellar tendon with a hammer and observe quadriceps contraction and leg extension. Some words about superficial reflexes. Typical example of superficial skin reflexes. There are abdominal reflexes, 3 of them, like on the picture. Stroke the abdomen lightly on each side in an inward direction above, directly, and below the umbilicus. Note the contraction of the abdominal muscles. The direction of our stretch, we can use handle of the hammer, for example, or stick, or even our finger, and slightly stretch in supine position with flexion of patient's knee for absolute relaxation of abdominal muscles along the costal arc. Upper reflex, TH7, 8, just to umbilicus. Middle abdominal reflex, TH9, 10, and along the inguinal fold, lower abdominal reflex, TH11, 12. Sometimes we neurologists use not TH but D, dorsal, for thoracic segments, roots, and we say D 7, 8, D 9, 10. These are the same like TH. Some words about pathways about tractus corticus spinalis or pyramidal tracts voluntary movement supply. This is the picture of this tract. You see the cortex, spinal cord, and brain stem, different levels of the central nervous system. There are two motor neurons in this tract. The upper motor neuron lies in precentral gyrus. Axons of these neurons descend their bundles through their internal capsule, cerebral peduncles, and ventral pons through the whole brain stem and decussate on the border of medulla oblongata and spinal cord. The first order neurons, there are neurons of fifth layer of precentral gyrus. There are giant bat cells, and axons of these neurons are upper motor neurons of the corticospinal tract. Then, after decussation, fibers go down in funiculus lateralis until the needed level for the innervation of the needle muscles. What does that mean? For example, if we want to move our arm, this is cervical level, level of cervical thickness. If we want to move our leg, this is a lumbar level, a level of lumbar thickness. So on the needle level, the information passes to the anterior horns, to the motor cells of anterior horns. The lower motor neuron lies in anterior horn. Axons exit spinal cord with anterior spinal root and go to the muscle. The name of first order neurons of this tract is the upper motor neuron. And if I ask you to show, please, the first or upper motor neuron. This is not only body cells in the precentral gyrus, but also axons of this motor neuron. So, where is the first motor neurons located? Body cells here, and axons, also parts of the first motor neurons, up to the second order neurons. The second order neurons, we said, lie here in anterior horn of the spinal cord, and the name of these motor neurons is the lower motor neuron of cerebral spinal tract. And this is not only body cells in the anterior horns, but also axons of peripheral spinal roots, peripheral nerves, and plexuses. Limb weakness results from damage to the motor system at any level from the motor cortex to muscle. There are two absolutely different pictures of lesion of the upper motor neuron and a lower motor neuron. And we will describe the upper motor neuron weakness or central paralysis and lower motor neuron weakness or peripheral paralysis. But previously I want to say a very important thing. We also besides the pyramidal tract or tractus corticospinalis lateralis, have anterior corticospinal tract. There are two divisions of the corticospinal tract, like on the picture. The lateral corticospinal tract or pyramidal tract we've described, and the anterior corticospinal tract. The lateral corticospinal tract neurons cross the midline at the level of medulla oblongata and controls the limbs and digits. The lateral tract forms about 90% of connections in the corticospinal tract. The anterior corticospinal tract neurons, the remaining 10%, stay ipsilateral in the spinal cord. but decussate at the level of the spinal nerve in which they exit and control the trunk, shoulder, and neck muscles and joint muscles. All muscles exhale muscles. In case of unilateral cerebral pathology above decussation due to the compensatory function of the anterior corticospinal tract, paralysis develops only in the opposite limbs. The function of the axial muscles like chewing, respiratory, abdominal muscles, pelvic muscles remains intact. In this regard, a person after stroke, typical unilateral stroke, or unilateral hemispheric injury can live with paralysis of the opposite limbs, but vital functions are not disturbed. This is very, very important compensatory function of the anterior corticospinal tract. Semiotics. Monoplegia. Plegia means paralysis. Only one limb is involved. Hemiplegia, both right limbs or both left limbs are involved. So, right side hemiplegia, left side hemiplegia. Paraplegia, both upper limbs or both lower limbs are involved. Maybe upper paraplegia, lower paraplegia. Paresis, not complete like plegia, but partial decrease of muscle power and active movements. Some example on the picture. For example, this lady has paralysis of this left side arm. You can see your active movements are limited compared with right arm, and this is even plegia. This is typical paresis of this left arm of this patient.
Так, опустили руки, в стороны руки и вверх. Вверх поднимаетесь. Теперь поворачивайтесь ко мне задом. Опустите руки, руки опустите. Так, руки в стороны, вверх. Теперь опустите руки, руки вытяните вперед. Хорошо.
This is our movie with patient with paresis. Now we will describe clinical picture, clinical sign of lower motor neuron weakness and upper motor neuron weakness. Start from the lower motor neuron weakness. We can observe lower motor neuron weakness when anterior horn lesion, spinal root lesion, and plexus or peripheral nerve lesion. Clinical features. 3A. Atonia or hypotonia with diminished resistance to passive stretch. Muscle tone is tested or controlled through the passive movements of extremities. Atrophy or muscle wasting. Wasting becomes evident in the paretic muscle within 2-3 weeks after the onset. Areflexia, depressed or absent deep reflexes, tendon and periosteal. There may be muscle fasciculation, involuntary contraction or twitching of muscle fibers under the skin, observed when anterior horn sends lesion. I want to show some pictures with examples of lower motor neuron weakness. This picture shows testing of muscle tone, passive movements, passive flexion and extension of extremities. On this picture you can see muscle atrophy. Compare deltoid muscle, for example, of this patient on left side and right side, and you can see muscle atrophy, very evident. The same patient with muscle atrophy of shoulder muscles. This is symmetrical atrophy of muscle, this patient. This is muscles atrophy of distal parts of extremities, around ankles. This patient with alcoholic polyneuropathy. One more patient with muscles atrophy, scapular muscles, and asymmetry of these muscles. This patient, young boy, with hereditary disease, a very serious hereditary disease, Duchenne muscle atrophy, or Erb's muscle atrophy, primary muscle hereditary myopathy, and diffuse pathology, primary pathology of skeletal muscles atrophy, diffuse muscle atrophy, and muscles weakness. This is the same patient, the very bright picture of muscles atrophy. This is our patient. This is muscle atrophy of tenor. Compare this side and this side. This is typical. Oh, it's not very good. Okay, next movie, please. Okay, compare left and right foot. And you can see typical gait. Typical gait, name of this gait with pathology of foot muscles is step push, lower motor weakness of foot muscles. Step push of the patient with alcoholic polyneuropathy. Look at his slippers. Oh. Step push. This lady has hereditary disease, Charcot-Marie, polyneuropathy, hereditary polyneuropathy, with bilateral step push of her feet.
А также мышц плечевого и плечевого до пояса уже так. Тетрапарезом примусом.
It's his gait.
То есть ему нет смысла здесь.
Хорошо.
This is a picture of muscles fasciculation. It was said muscles fasciculation we can see in case of body cells in anterior horn, spinal anterior horn, motor neurons pathology.
Okay.
Muscles fasciculation again.
Okay, will do.
One more patient with muscles fasciculation. Okay, this is muscles atrophy of hand muscles in this patient. One more patient with muscles fasciculation. Oh, this is very interesting and very heart disease, lateral amyotrophic sclerosis. This is only disease when we have pathology of both motor neurons. the upper motor neuron as well as the lower motor neuron. And this is very difficult to treat, and we don't have effective treatment for this patient. And this is combination. The clinical picture is the combination of the upper motor neuron weakness and lower motor neuron weakness, and this patient has atrophy and fasciculation of tongue muscle. The same picture, another patient, and also lateral amyotrophic sclerosis and muscles atrophy of tongue muscles. Let's describe clinical picture of the upper motor neuron weakness. Upper motor neuron weakness results from motor cortex lesion, brain stem lesion, and folliculus lateralis of spinal cord lesion. Clinical signs. The first one is hypertonicity. The special name of muscles hypertonicity in case of upper motor neuron lesion is spasticity. Passive movement produce a clasp knife quality or phenomenon when a doctor can feel resistance only at the beginning of movement, extension or flexion of limbs. The distribution of muscles hypertonicity in extremities, upper and lower extremities, is not equal in different groups of muscles. For upper limbs, tone of flexors is more than extensors tone, and in lower limbs, tone of extensors is more than flexors one. This results in the spastic posture with the arm and the wrist flexed and the leg extended, Wernicke Mann posture, like on the picture. Hyperflexion of arm and hyperextension of leg, and this patient is after pathological process, for example stroke, in the contralateral, in this case right side of brain. In this case, with the leg in hyperextended position, our patients with hemiplegia, spastic hemiplegia, have hemiplegic gait. The leg is extended and the toes forced downwards. When walking, abduction and circumduction at the hip prevent the toes from catching on the ground, forming a semicircle. This is old lady, our patient after a stroke with typical Wernicke Mann posture, with hyperflexion of arm and hyperextension of leg. This is the gait and position of the patient, a little bit dark movie, after stroke. One more patient after stroke.
Так, назад идите.
Задом?
Поворачивайтесь, поворачивайтесь, идите назад.
Typical hemiplegic gait with hyperextension of leg.
Назад ко мне, поворачивайтесь, идите ко мне.
In case of spastic paraplegia, with both lower extremities are affected, when patients have lower spastic paraplegia, we have diplegic gait. Strong abduction at the hips can produce a scissors-like posture of the lower limbs. The hips and knees are flexed and adducted, with the ankles extended and internally rotated. So, knees together, feet apart. Like in this case, this is patient after spinal stroke. biplegic gait, lower spastic paraplegia,
Так.
and very, very bright picture.
Иди, иди, иди. Смотри на меня, Толя. Смотри на меня. Молодец. Смотри, иди ко мне. Иди, иди ко мне. Иди ко мне. Иди, иди. Иди, иди.
This boy has cerebral palsy, named Little's disease. Little was an American doctor who described this disease. This is a spastic lower paraparesis in childhood after antenatal pathology during maternity, and this is very, very typical scissors-like gait of his boy. The second sign of upper motor neuron weakness is hyperreflexia of deep tendon and perostal reflexes. Biceps, triceps, knee jock, ankle jock are brisk and depressed or absent of superficial reflexes. For example, abdominal and gastric maybe. This is our patient after
Да,
stroke.
есть. Ага, хорошо. Да, давайте.
Look at his feet and slippers. You can see
Давайте, у меня уже заканчивается тут.
areflexia
Так.
of
А здесь не
and
наоборот. А здесь может быть из-за
hyperreflexia
спастики.
or normal
Спасибо,
reflexes
да.
on this leg and
Теперь слушай.
hyperreflexia of right leg. The next sign, pathological reflexes. The main is a plantar response, Babinski reflex, stretch with a stick or a handle of a hammer along the lateral side of the sole towards the big toe. Note the extension of the big toe. Normally we can see only flexion of the big toe. This is typical Babinski reflex on the picture.
Еще раз.
Hyperextension of big toe after stretching of the sole on this picture. And this is spontaneous bilateral Babinski reflex in case of low spastic paraplegia or paraparesis. Next sign of upper motor neuron weakness, this is clonus. Apply sudden and sustained flexion to the ankle or knee. Note a few persistent beats. It can be observed while examining knee and ankle jocks, several jocks instead of one jock in normal condition.
Еще. Еще раз.
Maybe clonus of
Еще раз.
foot
Нет, что-то не получается, да?
and knee.
Что есть? Расставьте.
Там такой клонус. Так. Ага.
Foot clonus on this.
О, отлично.
Muscle fasciculation and muscle wasting are absent. And I want to say again, it was said, dual innervations from each hemisphere results in sparing of the trunk with a unilateral upper motor neuron lesion. So, we described typical clinical pictures of the lower motor neuron weakness, 3A, atonia, atrophy, muscle atrophy, and areflexia of deep reflexes, and plus, in case of anterior horn pathology, muscle fasciculation. And we described upper motor neuron weakness, vice versa, muscles hypertonicity like spasticity, not equal distribution of muscle tone in upper and lower extremities, Wernicke-Mann posture, clasp knife phenomenon, hyperreflexia of deep reflexes, tendon and periosteal, and absence of superficial reflexes, for example, cremasteric or abdominal reflexes. Clonus, positive Babinski sign, and you see there are absolutely difficult clinical picture of the lower motor neuron weakness and upper motor neuron weakness. Thank you for your attention.